The objective of this brief presentation is to make an overview about pharmacogenomics of psychotropic drugs. What is pharmacogenomics of psychotropic drugs? Is probably the future and is probably the solution of a very serious and common problem that we have nowadays. Probably all of you knows that what we do now is to prescribe treatments on the basis of the clinical profile of the patient. And this leads to a process of trials and errors that is very time-consuming and, of course, is lengthening the suffering of the patient. What pharmacogenomics is promising to us is the possibility to make a tailored prescription. We can prescribe drugs based on the genetic profile of the patient. So the ideal scenario for the future is to make a blood or saliva sample from the patient and then make a laboratory analysis that allows us to know the specific drug that is useful and safe for our patient. This is easy to describe, but very difficult to achieve. So the target of this presentation will be to make you know which is the current status of this kind of research. Well, it is not future, it is already present. Because a few years ago, the FDA, for the first time, issued a news that is about carbamazepine. They saw that in some patients, carbamazepine have a serious problem, that is a serious skin reaction, Stevens-Johnson syndrome, that can be predicted on the basis of the genotype. This is why now in the US it is mandatory to do the genetic analysis for Asian patients taking carbamazepine in order to prevent this serious side effect profile. So it is already reality for one drug in the field of psychiatry. It is already reality for many other drugs in other fields of medicine, particularly oncology. So let's see which is the situation for other drugs in the field of psychiatry. We will talk briefly about antidepressants. The various drugs that we use are antidepressants, mood stabilizers, and antipsychotics. So there are a huge number of researches in all these drugs, but probably the most developed field in pharmacogenomics of psychotropic drugs is about antidepressants. What we know is that probably the most well-studied and the most well-known gene influencing antidepressant response is the serotonin transporter gene. Within the serotonin transporter gene, there is a very interesting polymorphism, the 5-HTT-LPR, in the promoter region, that changes the expression of the serotonin transporter. It means, in practical terms, that people with the short variant of the serotonin transporter gene polymorphism, they have less serotonin transporter in their brain. And to have a reduced number of serotonin transporter in the brain has a lot of important consequences. It means that those patients have a different anatomical brain. For example, a different amygdala reactivity, a different hippocampus. They have a different temperament, they are more anxious, and they respond less to antidepressants. So this is the only example that I will deal in detail in this presentation, just to explain you how a single gene variant can influence psychotropic drug response. So this was discovered more than 10 years ago in our group in Italy, and we saw that people with the short variant, they respond less to antidepressants. Less to antidepressant, we thought because they have less serotonin transporter in their brain, and you know that antidepressants block the serotonin transporter. But this was a naive view. The situation is much more complex. As I outlined before, the serotonin transporter, reducing the number of the serotonin transporter protein in the brain, frontal cortex and the raphe nucleus, it has a lot of consequences, not only reducing antidepressant response. So, to summarize it again, People with the short variant of the serotonin transporter have less serotonin transporter in the brain, different hippocampal volume, leading to a higher risk of depression, different amygdala reactivity, leading to a general arousal state that is a kind of anxiety in subject with the short variant of serotonin transporter, and they respond less to stressful life events. It means that they have a more, let's say, risky situation. If there are no stressful life events, they live in a good way. But if there are stressful life events, they cannot adapt. And then they develop depression and they respond less to antidepressants. But not only negative, it is also positive to have this kind of variant, because if you don't have stressful life events, they have a better adjustment in life. So I was a little bit in detail with this variant to let you know how a single gene variant, and we have about 7 million gene variants in our genome, how a single gene variant can have a very broad influence in human behavior, both in normal people and in affected people. So a single gene variant leading to a different brain anatomy, leading to a different brain functionality, leading to a different reaction to stress, and leading to a different response to antidepressant drugs, can have a very wide range of effects at a small entity, but very broad in human behavior. So this is the serotonin transporter gene, but there are a lot of other genes that influence antidepressant response. You can see that a lot of studies have been performed in this field, and in the slide you see all the positive signs are the positive studies that associated a specific gene with antidepressant response. A lot for serotonin transporter with some negative replication, but also other genes in other pathways of the brain. The situation for other psychotropic drugs is more or less similar. For antipsychotics, we have some variants that influence response and tolerability, but still not confirmed, as well as for lithium and for Alzheimer's disease. So to summarize this part, we have already a number of gene variants that influence efficacy and tolerability of psychotropic drugs, but we cannot use in clinical practice yet. Why? Because first, they are not widely replicated. Not in all samples we are sure 100% that these variants influence efficacy and tolerability. Second, because the effect is very small, 1, 2, 3% of the variants. Because a lot of other factors influence this aspect. You can imagine that response to psychotropic drugs is influenced by environmental factors, by hormonal factors, by health factors, but also from a genetic point of view. Not only gene variants are important. There are epigenetic mechanisms, that means how the gene expresses, and this is controlled by the environment. There are also other specific controls of genes, like copy number variation, splicing, when from gene you go to the protein. You have new mutations that arise from one generation to another. And finally, drug response is not a perfect phenotype, because drug response can change over time. You can have patients that respond to a specific drug in one episode and don't respond anymore to the same drug in a future episode. So maybe you can think, so there is no way to predict from a genetic point of view psychotropic drug response? I am not that pessimistic. I'm more optimistic. I think that eventually we will reach the situation when a series of genes can give us a specific profile for each patient of response, of non-response, of good tolerability, or poor tolerability. And to conclude my presentation, I would like you to know that in another field of medicine, specifically oncology, this is already the reality. In the slide, you see an example of what could be psychiatry in the future from a genetic point of view. The slide shows a product that is already on the market that is predicting the risk of recurrence after cancer. You know, it's a very troublesome issue. If a patient has cancer and it is cured, they want to know the risk of recurrence. And genetic, in this specific case, can help us. What you see that is called recurrence score is a combination of about 15 genes that give you the risk of having recurrence or not. In the right side of the figure is the situation when you have all the dangerous genes for recurrence. And in fact, the risk of recurrence is 33%. On the left part of the slide, you have a lucky situation where the patient has all the positive genes. That means protective versus recurrence. And in fact, the risk of recurrence is 3% only. So you see how it can be helpful genetic. And you can have intermediate situation where the risk is varying between 10 and 20%. So I imagine that for the future, it will be possible to have an information like the one that we have for oncology, giving us a combination of genes and environmental factor, a combination of genes and environmental factor that will give us the possibility for the patient to respond, to not respond to drugs, to have serious adverse events, or not having serious adverse events. Thank you for your attention.